Hello, class. The second chapter that we're exploring in this week 3 is Chapter 3, Diagnosis in the Assessment Process. Mental health assessment and testing play a crucial role in diagnosis and treatment. We talk about diagnosis being the cornerstone of the work that we do in clinical mental health counseling, as it serves as the foundation for identifying and understanding our clients' mental health issues, determining appropriate treatment plans, and monitoring their progress. So a proper diagnosis is essential in providing our clients with the appropriate treatment and support they need. Without that accurate diagnosis, our clients may not receive the most effective treatment for their specific mental health condition or conditions. Mental health assessments and tests help us identify the underlying causes of our clients' symptoms, allowing them to tailor treatment plans that can address the roots of the problem. Moreover, a correct diagnosis is essential if we are to monitor that progress of our clients. By conducting regular assessments and tests, we can track the changes in our client's symptoms. We can evaluate the effectiveness of our therapeutic interventions, and then we can also make adjustments with the client to their treatment plan as needed. This continuous monitoring is crucial for our clients. In addition, mental health assessment and testing can help reduce the stigma by providing our clients with a clear understanding. Then the diagnosis can help dispel misconceptions, can provoke greater awareness and acceptance. This encourages then others to seek help, to reduce feelings of perhaps embarrassment or shame, and then fostering a more supportive and understanding broader community in terms of support for mental health. Diagnosis, furthermore, is essential for research and advancement in our field of mental health. Accurate diagnoses help researchers identify trends, patterns, risk factors, right? And these can lead to the development of new treatment options, new interventions. Research based on accurate diagnosis can also help improve the diagnostic tools and criteria. And all of that can help lead to better mental health outcomes. We talk about the importance of diagnosis in terms of not only for the clients and treatment planning, but when we're working with other clinicians, and obviously for third-party payments, to deal with insurance companies, to deal with billing for Medicare, Medicaid, etc. We're going to take a few slides now and go through the DSM. Diagnosis is a crucial step in the field of mental health, as it allows for proper identification and the treatment of mental health disorders. It is a fundamental concept to the broader field of medicine, diagnosis. Diagnosis is derived from the Greek words dia, meaning apart, and gnosis, which is to perceive or know, knowledge, right? So, diagnosis refers to the process of identifying a medical condition by examining a patient's symptoms, medical history, and conducting tests. Similarly, we talk about diagnosis in terms of identifying a mental health issue, a behavioral health issue, by examining a patient or our client's symptoms, history, and conduct tests. Diagnosis, therefore, helps provide appropriate treatment and care for patients and clients. So it guides healthcare professionals, whether we're speaking in terms of a medical physical model or we're speaking in terms of mental behavioral health model. Within those systems, diagnosis is key in terms of the ability to accurately recognize and interpret the signs and symptoms presented by our patients and clients. Thereby, we need to have a thorough understanding of the various conditions, their manifestations, potential causes, etc. It's important that we analyze our clients' symptoms, conduct the complete assessment, that we narrow down possible diagnoses and determine the most likely, cause, the most likely identifiable condition, mental health, illness, disorder, etc. It's important that in addition to assessing symptoms and conducting all this assessment work and tests, that we also use a tests and assessment. Tests provide that data that can support and or refute a potential diagnosis. And of course, then once a diagnosis has been made, we're able to then develop that treatment plan with the client and then take a look at the goals in the treatment plan, and then further, depending upon the modality, what other medical professional, healthcare providers and professionals need to be involved. While the process of diagnosis may seem straightforward, it can be very complex and challenging, particularly where symptoms are vague or they overlap. Sometimes it's essential that we collaborate and that we consult in order to reach a conclusive diagnosis. So, the Diagnostic and Statistical Manual of Mental Disorders, DSM, is of course the widely used tool within the field of mental health, and it provides a standardized criteria for diagnosing mental health and behavioral health disorders. The DSM is published by the American Psychiatric Association. As you'll see, and you probably already know, we are in the 5th edition. It's used by clinicians, psychologists, psychiatrists, and other mental health professionals to diagnose and classify mental and behavioral health. The DSM provides that common language and that set of criteria to better understand and communicate around mental behavioral health, and it ensures consistency and accuracy. We know that the DSM includes a comprehensive list of various mental behavioral health disorders and illnesses, along with the specific criteria for each. These criteria typically include symptoms, duration, severity. As I mentioned, diagnosing can be a complex process. There are these overlapping symptoms at times. The DSM helps navigate that by providing clear guidelines for diagnosis. We want to use the DSM in that it is a tool that can help ensure that there's accuracy and consistency for effective treatment. In addition, there's criteria for diagnosing specific disorders, information on differential diagnosis, comorbidity, and it helps us navigate all these complexities. In the mid-1800s, the U.S. Census Bureau conducted a census that included counting the incidence, believe it or not, of idiocy and insanity in the population. This initiative was part of a broader effort to gather information about the demographics and social conditions of the country at the time. During this period, the understanding and treatment of mental health was, of course, vastly different from what we know today. Actually, the terms idiocy and insanity were used to describe most any form of mental illness. Cognitive impairments, intellectual disabilities. There was pretty much anything and everything was dumped into those categories, those two categories. Of course, we know that the categorization using those terms was problematic. And of course, it obviously reflected a lack of awareness and understanding of mental health issues. We also think of the time period. But the inclusion of questions around idiocy and insanity in the census was significant in that it provided insight into the prevalence of mental health within the population. Unfortunately, it also perpetuated stigma and discrimination. You can then easily leap to the terms idiots or insane being identifiably labeled terms coming out of the counting of these incidences of idiocy and insanity. And sadly, this, of course, was based on the limited understanding, and it served to further marginalize and isolate these persons from society. We also know that the data was collected, interpreted, was likely most unreliable and inaccurate. We know that mental health conditions are complex, multifaceted, cannot be accurately captured through a simple question on a census form, right? Additionally, the lack of standardized definitions and criteria based that there were just these two terms, idiocy and insanity, this all resulted in inconsistent and potentially misleading data. Let's fast forward to 1943. The U.S. War Department developed Medical 203. This was a groundbreaking advancement in medical technology that revolutionized the way medical care was provided to our soldiers on the battlefield. This innovation allowed medics to quickly and effectively treat wounded soldiers, saving countless lives during World War II. Medical 203 was a portable medical kit which contained essential supplies and equipment for treating injuries sustained in combat. This kit was designed to be lightweight, easily carried by medics, and thereby allowed for rapid response. The kit included bandages, antiseptic, pain relievers, and other medical supplies to treat wounds and injuries. One of the key features of Medical 203 was the inclusion of penicillin, an antibiotic. This antibiotic, penicillin, was still very new at the time. Penicillin was a life-saving medication that helped to prevent and treat infections in wounded soldiers, thus greatly improving their chances of survival. In addition to penicillin, this kit also contained other antibiotics and other medications that treated a variety of medical conditions. Another important aspect of Medical 203 was its focus on triage and quick assessment of injuries. Medics, therefore, were trained to prioritize treatment based on the severity of injuries, ensuring that the most critical cases received immediate attention. This method of triage help to prevent unnecessary deaths, and maximize the effectiveness of medical care in the field. Well, this Medical 203 was a game changer in the field of military medicine. Again, it allowed for medics to provide high-quality medical care, even in the midst of chaotic and dangerous situations in the battlefield. This kit was widely praised for its effectiveness and efficiency. And as I mentioned and reiterate, it did play a role in saving lives of soldiers during World War II. Well, Medical 203, also known as the Diagnostic Criteria for Use in Psychiatric Research, published in 1952 by the American Psychiatric Association, believe it or not, served as the foundation for the first edition of the Diagnostic and Statistical Manual of Mental Disorders. Yes, DSM-1, 1952. The first edition was developed to provide a standardized classification system for mental disorders, allowing for better communication among mental health professionals and facilitating research into psychiatric conditions. So Medical 203 was a landmark document in the field of psychiatry because it introduced a systematic approach to diagnosing mental disorders. Prior to the publication, diagnoses were often vague, right? Very subjective. And that, of course, would lead to inconsistencies in classification. Well, Medical 203 sought to address this by providing clear, specific diagnostic criteria for a range of psychiatric disorders, including schizophrenia, bipolar disorder, and depression. The publication of Medical 203 marked a significant step forward, right? This standardization of diagnosing mental disorders. This common set of criteria helped to ensure that patients were accurately assessed and received appropriate treatment. Well, the impact of Medical 203 extended beyond its immediate publication. It led to the groundwork, as I've said, for the development of subsequent editions of DSM. In 1952, I mentioned that the DSM-1 was first published. Subsequent editions continued to build upon the foundations that were laid by Medical 203. And each edition incorporated new research findings and evolving clinical practices. It was in 1980, I'm jumping ahead, that the DSM-3 was released. This was a significant update. And the neat thing about this, and this sets the stage for then what has then become of every edition since, in that the DSM-3 aligned its criteria with the International Classification of Diseases, the ICD, and the manuals of that since have followed and are revised in different editions, as well as with the DSM. By aligning these, this promoted consistency and compatibility between different diagnostic systems, different diagnostic systems. So one of the goals of DSM-3 was to provide this standardized set of criteria that could be easily understood and applied by clinicians all around the world. For you see, it aligned with the ICD at the time. Additionally, it introduced a more systematic approach to diagnosing mental disorders. There were clearer and more specific criteria. This all helped reduce variability. There was more detailed descriptions, more specific criteria that needed to be met for diagnoses. And it really helped to ensure that we moved away from objective evidence to we moved away from subjective judgment, and that diagnoses were based on objective evidence. Additionally, DSM-3, by aligning with ICD, also introduced a multi-axial system that classified different categories based upon clinical presentations, underlying causes, and fundamental impairments. This system allowed for a comprehensive understanding of mental health and provided a holistic approach to diagnosis and treatment. Now let's move to 1994. The DSM-4 was published in 1994 by the American Psychiatric Association. This again was a significant milestone. We note that it provided an even more comprehensive classification system and became the standard reference for diagnosing and treating mental health conditions, not only in the United States but around the world. Another key improvement was the inclusion of the multi-axial system, and this time it even allowed an expanded consideration of biological, psychological, and social factors. So the 5 axes that were in the DSM-4 were Axis 1 for clinical disorders, Axis 2 for personality disorders and mental retardation, Axis 3 for general medical conditions, Axis 4 for psychosocial and environmental stressors, and Axis 5 for global assessment of functioning. Again, a feature, more detailed descriptions. It included diagnostic criteria that was more expansive, prevalence rates, course of illness, differential diagnosis. All this came into being into the DSM-4. It also introduced new mental health disorders and revived diagnostic criteria for existing ones. DSM-4 included new disorders such as social anxiety disorder, post-traumatic stress disorder. There were revisions to diagnostic criteria for disorders like depression and schizophrenia. Despite its strengths, there was criticism that the DSM-4 faced because of its reliance on this categorical approach, which some argue really oversimplified the complexity of mental health. Well, all of this led to the criticism, right, leads to further revisions, which was the development of the DSM-5. The DSM-5 is the 5th edition of the Diagnostic and Statistical Manual of Mental Disorders. It is the guiding tool for mental health professionals in diagnosing and classifying mental behavioral health. It was first published in 2013, replacing the previous edition, which was the DSM-4TR that was published in 2000. So there was a text revision to the DSM-4. We also have a text revision to the DSM-5 as well. The DSM-5 included significant changes to the previous edition. Again, all aiming for more comprehensive, accurate classification. One of the main changes was the revision of diagnostic criteria. The updated criteria provided, it took into account more research, right, of course, and more clinical experience. The DSM-5 also included new disorders that were not in previous editions. Disruptive mood dysregulation disorder and hoarding disorder. Another important change is that the dimensional assessments to complement categorical diagnoses was added. This allows us to evaluate the severity of symptoms and their impact on the individual's functioning, providing a more comprehensive understanding of the individual's mental health status. DSM-5 also emphasizes the importance of cultural factors, the importance of cultural background, cultural beliefs, and practices. So cultural sensitivity, important, and brought into the DSM-5. Of course, there's always praise and criticism. There has been criticism about overdiagnosis and the influence of pharmaceutical companies on the diagnostic process. Of course, like I say, there's always praise and criticism. Again, as I referenced in the other previous slides in the development of the DSM, the alignment of DSM-3 with the ICD, we have the DSM-5, which again remains aligned with the ICD-9 and 10, and hot off the presses, literally, nearly, ICD-11 will be coming out soon. And we are, of course, do have the DSM-5 TR, and you'll note that we've moved away from Roman numerals, so that now this is better able in terms of computer software that we can now follow with the revisions and additions having the dot number, right? 5.1, 5.2, not unlike operating systems, right, on our other technology. We went back to a single axis system. We know the DSM-5, that is, eliminated all those multiple axes. Let's see. I want to reference the GAF for a moment. The Global Assessment of Functioning Scale, GAF, was commonly used in the field to assess a person's overall level of functioning. There was a numerical scale ranging from 1 to 100. So lower scales indicating more severe symptoms and impairment in daily functioning. Well, there's been a shift away from the GAF, and now it's discontinuation. One of the reasons for getting rid of it was its lack of reliability and validity. There was also a lack of clear guidelines on how to assign this numeric score. Of course, that led to inconsistencies, etc. It also was limited focus on symptom severity. The scale primarily assessed symptoms and impairment, and of course did not take into account other factors. So it was quite narrowly focused. So, in place of the GAF, mental health professionals are now using more comprehensive evidence-based tools to assess functioning. And these tools take into account broader factors: social functioning, vocational abilities, quality of life, right? By using more comprehensive assessments, we can better tailor treatment plans, right, to meet the needs of our clients. Additionally, we now can list medical conditions alongside with the DSM diagnosis, and we can enlist the psychosocial environmental stressors along with the diagnosis. This expanded the V codes that came from ICD-9, which we have in the ICD-10 are Z codes. So we're continuing to, when making a diagnosis using the DSM-5, it's important, as I've said repeatedly, that we gather information through interview, observation, testing. We compare it to the criteria outlined to determine if the individual meets the criteria. The DSM-5 provides diagnostic criteria for a wide range of mental behavioral health. We have mood disorders, anxiety disorders, psychotic disorders, substance use disorders, personality disorders, etc., etc. Reporting a diagnosis involves documenting the presence of or absence of specific symptoms and meeting the criteria for a particular disorder. Let me repeat that. When we use the DSM-5 to report a diagnosis now, we are not only documenting that diagnosis, but we're also reporting and documenting the presence of or absence of specific symptoms and criteria. Thus, we're reporting diagnoses now in a clear and accurate manner. And that, of course, ensures effective communication between healthcare providers, ensures the best possible, hopefully, care, right, for our individuals, for our clients. So it's important that we use the current DSM in a very thoughtful, responsible manner. We should exercise extreme caution to avoid overdiagnosing and misdiagnosing. We need to be mindful of cultural factors that may influence the presentation of symptoms and tailor our assessments accordingly. With the DSM-5, within it we have also subtypes, specifiers, and severity levels. These are important components that are used to provide a more accurate, nuanced understanding. Subtypes are variations within a particular disorder that distinguish different presentations or manifestations of the symptoms. For example, in the case of major depressive disorder, subtypes may include with anxious distress or with mixed features. These subtypes tailor the treatment strategy to better address the specific needs and symptoms of our clients. Specifiers further refine the diagnosis by providing additional information about the course, severity, or features of the diagnosis. Specifiers often describe specific symptoms that may be present during a particular episode of the diagnosis, the disorder. For example, a specifier for bipolar disorder may indicate whether the individual is currently experiencing a manic, hypomanic, depressive, or mixed episode. So these specifiers help paint that very detailed picture of our client's specific symptoms and the presentation. We then have severity levels. These are used to indicate the degree of impairment or distress. There are varying levels of severity for each disorder, ranging from mild to severe. Severity, again, help us determine the appropriate level of intervention and treatment needed. For example, a diagnosis of post-traumatic stress disorder with a severe level of severity may require more intensive therapy or medication management, perhaps compared to a diagnosis with a mild severity level. One important aspect within the DSM-5 in terms of subtypes, specifiers, and severity is the inclusion of these specifiers which provide additional information. One type of specifier that is commonly used is the specifier for whether a certain symptom is present or absent. The specifier for if a certain symptom is present, and the specifier for current severity. So we have that subtype, specify whether. So the specifier for whether a symptom is present or absent is used to indicate whether a specific symptom is present in that client's presentation. For example, we might have major depressive disorder, and one of the specifiers may be with anxious distress. So this specifier is used to indicate whether the person's symptoms include feelings of anxiety or worry. The specifier for if a symptom is present is used to indicate the severity or intensity of a specific symptom. For instance, in the diagnosis of generalized anxiety disorder, one of the specifiers is with panic attacks. So we have that specifier used that's to indicate that the person is experiencing panic attacks as part of their anxiety symptoms. Then we have the specifier for current severity, which is used to indicate the severity. For example, in the diagnosis of alcohol use disorder, one of the specifiers is mild, moderate, or severe. These specifiers are used to indicate the level of severity of the person's alcohol use. Provisional diagnosis in the DSM is a temporary diagnosis, which is made when there's uncertainty about the true diagnosis. It's often used when a thorough assessment is still ongoing and or more information is needed, right, to make that definitive diagnosis. Provisional diagnoses are denoted with writing provisional next to the diagnostic or the diagnosis code. This indicates that the diagnosis is not yet confirmed and may change as more information becomes available. So, why would one use a provisional diagnosis? Well, it might be necessary when a patient presents with symptoms that are not immediately clear or fit neatly into a specific diagnostic criteria. In these cases, a provisional diagnosis can help guide treatment decisions while further evaluations being conducted. Another reason for provisional diagnosis is when a patient is in crisis and needs immediate care. So in these situations, it may not be possible to conduct this full comprehensive assessment before making a diagnosis. So a provisional diagnosis allows the treatment to start quickly for that client, and then the adjustment and the diagnosis can be made as more information becomes available. I make an important note. Provisional diagnosis is not, never, ever, no way a substitute for a thorough assessment. We need to continue to gather information and reevaluate as needed. If an initial diagnosis is incorrect, it can lead to ineffective treatment and potentially harm the patient. Within the DSM-5, there's a term that's frequently used to indicate that a particular disorder is being considered but has not yet been definitively diagnosed. This term is rule out. So when a clinician writes rule out in a patient's diagnostic evaluation, it means that there are symptoms present that could potentially be indicative of a specific disorder, but further evaluation and assessment are required before that formal diagnosis can be made. So it helps consider and evaluate all possible explanations for those symptoms before settling on that final diagnosis. One of the key reasons why the rule out concept is important is that many disorders, illnesses share similar symptoms or can present in a way that overlap with others. So by using that term rule out, we can ensure that we are carefully considering all potential diagnoses and not just jumping to conclusion based on a surface level symptom alone. Rule out also helps prevent misdiagnosis and premature labeling of a patient with a particular disorder. We know that mental behavioral health is complex, is multifaceted. It's not uncommon for clients to present with symptoms that are not neatly fit within a diagnostic category, right? So by taking the time to rule out other diagnoses, we can ensure that our clients receive the most accurate, appropriate treatment. It's important to note that rule out does not mean that our client's symptoms are any less valid or significant. Rather, on the contrary, it represents a thoughtful, comprehensive approach to understanding and addressing the mental health concerns. So by ruling out other diagnoses, we are really providing a more targeted, effective intervention tailored to the needs of that client. Another component is within the diagnostic criteria found within the DSM-5 is the specific traits or symptoms that must be present in order for a diagnosis to be made. Traits are essential in understanding and diagnosing mental behavioral health. They provide valuable insights into the person's thoughts, feelings, behaviors. These traits are often categorized into different symptom clusters, such as mood symptoms, cognitive symptoms, behavioral symptoms. By identifying and understanding these traits, we can better assess and treat. For example, traits associated with mood disorders may include persistent feelings of sadness or hopelessness, change in appetite, sleep, loss of interest in enjoyable activities, right? Cognitive symptoms, on the other hand, may involve difficulty concentrating, difficulty making decisions. Behavioral symptoms could be irritability, agitation, right? So it's really important to note the presence of these traits, and that they alone, however, do not make a diagnosis, therefore, to be made, right? The presence of the traits alone is not enough for the diagnosis. We need to consider all the criteria, right? Duration, frequency, the impact of the traits. And we must rule out any other potential causes, contributing factors, etc. So it's important that we understand these traits. And they provide for very targeted therapeutic treatment interventions. Additionally, one important aspect of diagnosing within the DSM-5 in terms of provisional diagnosis is the concept of provisional diagnosis by history. This means that a mental health professional, we may make a preliminary diagnosis based on the patient's history and symptoms, even if all the criteria for a specific disorder have not yet been met. This again allows for a timely intervention and a treatment plan to immediately begin while further assessment and evaluation is conducted. So we're relying on the information by history that perhaps includes the patient's presenting problems, their symptoms, duration, family history, medical history, etc. We also have, it's important to note that provisional diagnosis by history is not a final diagnosis. Further assessment and evaluation are necessary to confirm, right, diagnosis and develop the appropriate treatment plan. Additionally, we have self-reporting, which is a very common method, right? Our clients provide information to us about their symptoms, feelings, etc. So we have this self-reporting, which does have its limitations, is it may not always accurately reflect or clients may not always accurately report their symptoms. So provisional diagnosis based on self-report can help us better understand the symptoms while they seek appropriate help. Again, provisional diagnosis by self-report should not be what we rely on for a diagnosis and treatment. It can be valuable, but should be used again in conjunction with comprehensive evaluation and assessment. And again, we need to continually make sure that a final diagnosis is identified. Other specified disorders within the DSM, 5th edition, refer to mental health conditions that don't fit neat and tidily into specific categories, but are still causing very significant distress or impairment in functioning. These disorders included within the DSM ensure that our clients receive proper diagnosis and treatment, even when their symptoms don't align with a specific diagnosis. One example of an other specified disorder is unspecified feeding or eating disorder, right? Another example of other specified disorder is mixed anxiety and depressive disorder. Additionally, the DSM includes other specified neurodevelopmental disorders, such as social or pragmatic communication disorder. So unspecified disorders refer to mental health conditions that, again, don't fully meet the criteria. So they're often characterized by symptoms that cause distress, impairments in daily functioning, right, don't fit in. One example of an unspecified disorder is unspecified anxiety disorder, right? So we can use unspecified, perhaps when an individual experiences symptoms of anxiety such as excessive worry, restlessness, right, muscle tension, but they don't meet the criteria for any of the specific anxiety disorders. Another example of unspecified disorder is unspecified depressive disorder. So unspecified disorders are not to be, however, this catch-all category. They are intended for a temporarily placeholder for individuals experiencing symptoms that don't neatly align, right? Treatment for unspecified disorders oftentimes includes a combination of therapy, medication, and a variety of other perhaps lifestyle changes, etc., that address symptoms and improve overall well-being and functioning. There are 22 specific diagnostic criteria. We have neurodevelopmental disorders, schizophrenia spectrum and other psychotic disorders. We have bipolar and related disorders, depressive disorders, anxiety disorders, obsessive compulsive and related disorders, trauma and stressor related disorders. These are the categories, the diagnostic categories, these 22 within the DSM-5. We have dissociative disorders, somatic symptom and related disorders, feeding and eating disorders, elimination disorders, sleep-wake disorders, sexual dysfunctions, gender dysphoria, disruptive, impulse control, and conduct disorders. We have substance-related and addictive disorders. We have neurocognitive disorders, personality disorders, paraphilic disorders, other mental disorders. We have medication-induced movement disorders and other adverse effects of medications. We have other conditions that may be a focus of clinical assessment. It's always important to check in terms of other medical considerations as well, and that we should use the ICD-10 when reporting a medical condition. V codes are a category of diagnosis within the DSM-5 that are used to describe the psychosocial and environmental factors that affect an individual's mental behavioral health. It's important to note that these codes are not mental disorders themselves, but they can be important in understanding the context of the mental behavioral health issue. So the V codes provide valuable information for treatment planning and can help us address underlying causes of a person's symptoms. The V codes represent a different aspect of their life. Some V codes include problems related to family upbringing, educational challenges, occupational stress, relationship issues, etc. V codes can also be useful in situations where a person's facing a major life event or transition, such as divorce, loss of a loved one, relocation, significant life events. Z codes are used to classify factors influencing health status and contact with health services. Again, Z codes are also not considered mental disorders, but can be used to provide that additional information. Z codes can help us understand the context in which the patient's symptoms are occurring, such as their living condition or situation, their social support, their network, history of trauma. They can also be used to indicate a person's need for specific services, such as counseling, rehab, support groups, etc. Some common examples of Z codes are Z63.0, problems in relationship with spouse or partner, is one. Again, these codes all provide that valuable insight into the overall well-being and can help guide a specifically targeted treatment plan that looks at social environmental factors. It's also important to note that Z codes can be used to track public health records and identify populations at risk for certain health issues. This, of course, helps healthcare providers and policymakers develop targeted interventions to address root causes of poor health outcomes, can be help in terms of focusing on research. Cultural considerations play a critical role. The DSM-5, it's important to recognize, as I've said, that mental health is influenced, right, by a multitude of cultural factors, beliefs, values, norms, traditions, right, our worldview. Well, one of the key cultural considerations with the DSM-5 is the concept of cultural competence. Cultural competence refers to the ability of us to better understand and respect the cultural backgrounds of our clients and then adapt practices accordingly. This includes being aware of those cultural differences in terms of symptom expression, their help-seeking behaviors, and treatment preferences. Another important aspect is the recognition of cultural variations in the prevalence and presentation. So it's important that we acknowledge these variations and avoid, because they can help us avoid misdiagnosis, and we want to make sure that our clients receive appropriate care. We also recognize that the DSM-5 recognizes the impact of cultural factors on the assessment and treatment. So culture can influence how a person both perceives and experiences their symptoms, how they cope with stress, what treatment modalities they find acceptable. So it's important to take into account cultural considerations in a very important way. And the DSM-5 has targeted the importance of that. One tool that's been developed to help us is the Cultural Formation Interview, CFI. It is in the DSM-5. It's a structured interview that's designed to help us gather information about a person's cultural background and how that may be influencing their mental health. It consists of a series of questions over a range of topics. It's designed to be used in conjunction with a standard diagnostic assessment like the DSM-5. So the CFI allows us to then tailor the assessment and treatment approach to that specific client and better meet their needs. An important benefit of the CFI is that it helps us avoid making assumptions, right, based upon cultural background and bias, right? We need to gather information directly from the client so that we better learn from them how to understand their beliefs, their practices, right? To gain an understanding of how culture influences them. Cross-cultural symptoms in the DSM refer to the presence and manifestation of mental health symptoms that vary across cultures and ethnic groups. So it's great that it now has, this version now has aspects of, again, a broader cultural consideration by including cultural symptoms as well as cross-cultural issues. This has been a great, of course, a huge new piece of inclusion of important work and important information that has been lacking within the DSM. So please take some time to explore and review the Cultural Formulation Interview, the CFI. Some final thoughts. Remember that the DSM is one piece of the total assessment process, right? We need the clinical interview. We need a complete assessment process, and that the DSM-5 is part of that, right? Those are my final thoughts as we conclude this chapter. Thank you.